So, I got asked to give a talk about how to stay out of trouble treating cervical fractures. So it's not a very database topic, and I think once you get a little bit older, these are the talks they want you to give. And so, we fail a lot, and some of these might be my case, but most aren't. But I've treated these problems, and we fail a lot on our road to success. So I'm going to go over some subtle clues of instability that were missed. Understanding fracture patterns can be a problem. I'm going to focus a little bit on recognizing the limits of fixation, mostly in regard to facet dislocations, and then also being prepared to respond to the unexpected. And this is really a series of cases. So recognizing subtle clues of instability. We all do this with ankylosed spines, with a true rigid, bony, stabilized spine, but elderly spines that are stiff behave the same way. And this is often unrecognized. You can see in this patient, they're not ankylosed, but this spine doesn't move. And you can see the subtle clue of an extension injury, and you can even see some subtle fracture. This was not recognized at an outside facility. We received the patient after they cleared the collar, they dislocated and became quadriplegic. So these patients, these elderly patients behave like ankylosed spines, and we have to be aware of it. We also have to be aware of who's calling us. Many of you probably now receive calls from outside facilities. This was a call about a 66-year-old male, fell from standing normal, had a mild T1 compression fracture. They asked if they could just put in a collar and follow up in clinic. I'm being leery like an old fox, and I looked at this and I said, okay, there is compression, and it may be simple, but that to me looks a little bit wide. And I said, this patient needs to come to the hospital, and there's the MRI. You can see this is not a T1 compression, but this is a flexion distraction injury. And if you look at the CT better when you get a chance, you can see subtle clues of facet injury. This is not a stable injury by any stretch of the imagination. We were told they were neuro-intact, but the patient tells you when they were injured and fell, they had tingling and numbness in the hands. It took 5 or 10 minutes to go away. This patient also had a mild cord injury, and this is why that's in the classification. So be leery of what you're told. Look at the imaging, and we learned that as residents not to be trusting, and this patient got a fusion. Understanding fracture patterns is important to avoid mistakes. We're all sort of aware of this injury, the floating lateral mass. This is a 2-level injury. This is a paper with not large numbers, but most papers on this injury have small numbers, and they all say the same thing. If you try to treat this with a 1-level fusion, your risk of failure is pretty high. Not all of them fail, but this is a 2-level injury. Even though the subluxation occurs at the caudal end, it's a 2-level injury. Similarly, in the cervical spine, unlike the thoracolumbar spine, subtle neurological complaints have meaning. In the thoracolumbar spine, we rarely see a normal CT that has significant injury, but that's not true in the cervical spine. This is a 69-year-old, very healthy, active male, a good skier, failed skiing, came in with neck pain, left arm paresthesias. The radiologist read this CT as negative, and even in retrospect, I would agree. This C-spine was cleared by the trauma service. We never saw him until a month later. But what they forgot is that they did image the patient, but this patient had focal neurological deficit. They had neck tenderness, and although this patient was cleared radiographically, they weren't cleared clinically. And, we need to do the same thing. There's a reason we do what we do, and they need clinical clearance, even if they're a physician that you don't want to inconvenience. Because he came to see us a month later. Now he still has left arm paresthesias, neck pain. He now has wrist extensor and grip weakness. You can see the traumatic disc herniation and the disruption of his ligaments. And you can see this is an unstable level on flexion extension and gets an ACDF. Recognizing the limits of fixation. This is really the big one, and I have most examples on this because, In cervical facet dislocations, we have a lot of choices. We can go anterior, posterior, and all these things can work pretty well. We have a lot of ways to tackle this problem as long as we're aware of the pitfalls of treatment. So our goals are simple: cord decompression. This can be done with a traction reduction. It can be done by removing disc herniation anteriorly. We can realign it. That may complete our decompression. It may require a discectomy if there's anterior disc on the cord. Then our stabilization can be done anterior, posterior, or both. We have to decide how to do it. So there's a lot of acceptable means in order to do this. You can do a traction reduction, then MRI to assess for disc herniation. At that point, your choice is to stabilize anterior, posterior. If there's disc herniation, it's going to force you anterior. If there's not, you can do a posterior stabilization. If traction fails, then you may want to consider an MRI and consider a posterior open reduction if there's no disc herniation. If there's disc herniation, again, you're forced to the front. Some people choose to go straight to the OR and say, I'll just do an anterior discectomy, I'll eliminate that problem, then I'll do an anterior reduction and stabilize them anteriorly, okay? That's assuming there's no contraindications to anterior fixation alone. You'll see this is where people get into trouble. This is probably the main area that they don't recognize. So if an MRI is the first step and there's no disc herniation, you can do an open posterior reduction. The one absolute no-no is open posterior reduction without MRI. So anterior stabilization, we get to leave them supine, the approach is easy, we all like it better. And it's usually biomechanically adequate. The problem is if we overstract the discs and we lose the ability for the facets to abut one another and resist translation, that thing's going to fail. So that's not only true if we overdistract, but it's also true if we have large facet fractures. It's also true if the end plate's fractured and won't support our graft. Multiple examples of this. This is the biggest problem we see all the time because everybody likes to leave the patient supine and do a simple surgery. This is failure to recognize a vertebral body fracture. Looks okay initially, and it's doomed to failure. This is a case where they failed to recognize the facet fractures and the inability to resist translation. I don't have the initial films, but this is early post-op. It's already failing translationally, and this thing is going to fail dramatically. So if you recognize that, you've done this and you recognize that, you need to take that patient back the next day and deal with this with additional posterior surgery. This is the 21-year-old who had upper extremity paresthesias. This particular surgeon chose not to do an MRI, go to the OR, do an anterior discectomy to address the disc problem, and anterior reduction. The problem is when you do an anterior reduction, verifying that reduction can be very difficult. On the bottom right, you see one of our West Virginia patients. You're not seeing a 5/6 reduction on that patient. So you have to verify it. Today we have the advantage of an O-arm. And if you have that patient, you may need an O-arm spin because this patient had an anterior discectomy but no reduction. They thought they were reduced, not reduced. Another problem with anterior fixation. So, you know, the problem is I would rather do an anterior if I don't have the contraindications. But in reality, I'd be hard-pressed to find a failure of posterior fixation. I'm sure they exist, but all the failures I see are from anterior alone surgery. If you go anterior, you can go anterior posterior. Lastly, be prepared for the unexpected. This is a 62-year-old ankylosed spine. We know these are dangerous. He's neuro intact. He's not displaced at this point, but they're dangerous. The surgeon took it to the OR, did everything right, did a glide scope intubation, put him in tongs, got baseline pre-flips, did a Jackson table flip. Pre and post CT, C-arm pictures looked pretty good, and the neuromonitoring stayed stable. They did an in situ fusion. They did recognize that it had sagged a little bit into extension, which they often do. Did an in situ stabilization. Things were going well. When they were finishing the posterior stabilization, getting ready to close, suddenly they lost signals. They troubleshot, the signal persisted. So the thought was this was sagging into extension, and the cord compression was likely posterior, and they were able to recognize this immediately, do a posterior decompression, And you can see they were probably right when you can get a better look at sagging into extension, and you can envision where the bone might have been having a pincer effect into the cord posteriorly, post-op MRI. So be aware of this, prepare for this. The monitoring in this case helped. The patient had some persistent deficit, but probably could have been way worse. So in summary, care of cervical trauma, those of us who do a lot, it can be really rewarding. The indications are pretty clear and the outcomes are pretty good. But there are pitfalls that can change the first premise completely. You have to recognize nuances of each fracture pattern. You have to understand the limits of fixation techniques. An anterior fixation for jump facets can work, but it has its limits. You have to recognize and then understanding your own limits. Thank you.